My name's Elizabeth Salisbury-Afshar. I joined Randy and team in August of 2020, so I've been here for about a year and a half. And I'm an addiction medicine, family medicine, and public health physician. And today I'm going to be giving this grand rounds on buprenorphine initiation in the age of fentanyl. So these are the learning objectives for today, and I already made a disclaimer, but I am hoping to have some discussion throughout. So I'm like, you've been warned. I hope people will be willing to come on screen and talk a little bit about some of the cases that I have interspersed throughout. But our learning objectives are to be able to describe local trends related to opioid supply, to describe the challenges of buprenorphine initiation in the fentanyl era, to be able to talk about 3 potential approaches to initiating buprenorphine, and finally to counsel on reducing fentanyl-related harms. So these first slides are really background slides, and I'm going to move through them rather quickly because I'm guessing a lot of us have seen them many, many times, but I think it's just important for sort of laying some groundwork. So this is a slide from the Centers for Disease Control that really highlights sort of at a national level the sort of evolution of our opioid overdose crisis, with really increasing rates of prescription opioid related deaths from about 1999 until around 2010. That's around the same time, around 2010, we started seeing significant increases in heroin related overdose deaths. That's that sort of medium blue line. And then really in 2013, lots of increase in fentanyl-related overdoses. And then around 2016, fentanyl and synthetic opioids were the leading cause of opioid-related overdose death. So we have continued to see this evolution in sort of the predominant opioids involved in death, as well as the predominant opioids available, and this varies some from region to region. So overdose death rates nationally have sadly continued to increase in almost all states. This is, again, just sort of snapshot point in time. I wanted to give people a sense of where we are in Wisconsin in terms of total overdose death rates. You know, we've seen really over the last decade, really starting in the Northeast, really high rates of overdose related to fentanyl. And as fentanyl has continued to infiltrate the opioid drug supply, as we move west, we've seen increasing rates of overdose in other states as well. Wisconsin is sort of in this top tier. So dark green is the highest rates of opioid overdose death. Wisconsin is in this top tier of states in this sort of 21 to 57 per 100,000 deaths, or per 100,000 people, excuse me. But I guess if there is good news in this slide, it's that of all those states in dark green, we are the lowest. So not great that, you know, we're still in the highest sort of quartile, but at least among those states, we're in the lower range. I know we've heard about this a lot in the news, but just visually wanted to show, unfortunately, we have continued to see increases in overdose deaths during the COVID pandemic. You know, and again, lots of reasons for this: increasing isolation, reduced access to services, particularly in the early months of COVID pandemic, reduced access to harm reduction services. But I think, you know, the overall picture is sadly things have just continued to get worse. And so when we think about intervention and how we're responding, this continues to be a major ongoing public health crisis. And then in Wisconsin, so this is the most updated, most recent available data. Dane County, folks are probably aware, is down here. And so in Wisconsin, Dane County has one of the highest rates of opioid overdose death. Milwaukee County actually has the highest rate. But again, sort of in terms of where we are within the state and where we are within the country, we do have relatively high rates of opioid overdose, and this continues to be a big issue for us. So fentanyl, I showed the map looking at national rates, just to give folks a sense of what we're seeing in terms of overdose deaths in Dane County. In 2020, there were 123 documented opioid overdose deaths, and about 90% of those, 106, involved a synthetic opioid. The remaining deaths were either not able to be identified, like what type of opioid, or prescription opioids or heroin alone. But the vast majority are now involving fentanyl. So this has been an evolving epidemic. We've seen the transition from prescription use to heroin use. And a lot of this has been attributed to the fact that opioid dispensing, we have, in many cases, very appropriately tried to reduce opioid prescribing and opioid dispensing. We've seen about a 35% reduction between 2006 and 2019. So lots of, reduced prescribing, but there was still demand for opioids. And so there has been a lot of speculation that that cessation of prescribing has driven illicit use. Some of that I think is up for controversy. I don't think in any way, shape, or form that is the only cause of increased illicit use or increased rates of death. But definitely, I would say at this point, there's sufficient data to say that it has contributed. We have increasingly seen synthetic opioids infiltrating the heroin supply, whereas sort of in the early days, like early, 2011, 2012, even up through 2015, we really talked about this being contamination. Increasingly, especially in the Northeast, all the way through to places like Wisconsin and Illinois, fentanyl is really the primary at this point. Like it's hard, as we've probably all had patients tell us, it's hard to find real, actual heroin. So whether it's what you're looking for, whether you want fentanyl, or whether it's all you can get, at least what we're seeing sort of clinically and what we're hearing from our patients is that this is really the main thing that's available right now. I should also acknowledge a handful of these slides were created by a colleague of mine, Dr. Hannah Snyder, who's at UCSF. We gave a similar presentation together. And so rather than remaking them, I have just adapted them with her permission. So anytime that's the case, I did include a little credit at the bottom of the slide. So I think a lot of times we hear about fentanyl as this relatively new problem. It's just important to sort of put it into context. It was synthesized in 1960. It's been FDA approved for anesthesia since 1972. The first published reports of there being non-medical use were in the 1980s, and it was primarily among physicians, anesthesiologists, surgeons, people who had access to these meds for medical purposes, who themselves found that they were getting some positive effects from using them. Then in the 90s, we started hearing reports of non-medical use of fentanyl patches, people chewing them, sucking them, trying to get the fentanyl out in various ways other than just applying them transdermally. In 2006, there was actually a non-pharmaceutical fentanyl outbreak among heroin users in Chicago, Detroit, and Philadelphia. Interestingly, that was tracked just to a single clandestine lab in Mexico. And as soon as they shut that lab down, we didn't see more fentanyl overdoses until a few years later, in 2013, when we started seeing this significant rise in overdose deaths related to fentanyl. Massachusetts did some interesting early work to say, well, is this really fentanyl that's being produced illicitly, or sort of non-pharmaceutical grade fentanyl, or is it possible that this is actually fentanyl patches, or fentanyl that's being pharmaceutically developed and diverted in other ways? And what they found consistently was that it was illicitly manufactured fentanyl. Then in 2014, we started seeing counterfeit pills enter the market. So any number of pressed pills, increasingly seeing that there was more and more fentanyl in them, regardless of what they were being sold as. And then in 2016, more carfentanil associated deaths. And then since about 2016, also, we've seen fentanyl become the leading opioid involved in overdose. So it's been around for a long time. It's obviously become an increasing problem. And so I don't want to spend too long here, but I think it is important to acknowledge that in terms of drivers of fentanyl and increasing rates of fentanyl use, there are sort of things that have happened that have both increased demand, like restrictions on opioid prescribing, as well as increasing availability. Increasing labs in China, it's because it's so potent, it's able to be shipped in a more compact way because it's a small volume, and it's highly profitable. So in a lot of ways, it's kind of been like a perfect storm. Um, Again, happy to talk about this later, but a lot of times they're just questions like, well, why would drug dealers want to sell this, or how, why is this the new thing? Why is this instead of heroin? And I think the short answer is that it's easier to produce. You don't have to have fields of opium or fields of poppies. You can produce it in labs. The labs can be pretty small, and then they can ship it. And that's largely how this initially started, was that it was coming out of China. It was really high purity fentanyl that would be shipped in these sort of small containers through normal sort of international shipping channels. In recent years, we're hearing more and more about stuff still being made in China, but then either going to Canada or going to Mexico. And at that point, it's being mixed with other drugs. the fentanyl coming in via these routes are thought to be much less pure, have a lot more contaminants. And this is also, at least per DEA reports, where they're thinking that some of the mixing with stimulants or other drug supplies, as well as the development or the making of pressed pills, is happening. And then in very recent years, we're hearing more and more about actually labs manufacturing fentanyl in Mexico. So again, everything sort of continues to evolve, and I'm sure we're always a few steps behind what's actually happening, but this is what we know to date. So the pharmacology here, folks are probably familiar with a lot of this, but you know, the reason this has become such a problem is because fentanyl is so much more potent than heroin. So if someone's used to using heroin and they're used to using whatever volume would be a normal amount and they accidentally are exposed to fentanyl, their risk for overdose goes up substantially. Additionally, even though most of the opioid supply locally contains fentanyl, right? When you get a white powder, you don't know, is that 5% fentanyl? Is it 10% fentanyl? Is it 50% fentanyl? And so it's really hard to know how to adjust use. It's highly lipophilic, so it rapidly crosses the blood-brain barrier. Its effects happen at least very, very quickly, even compared to heroin. Often it hits people really quickly. And it also is distributed to adipose tissue, which means that sort of similar to how cannabis is absorbed into adipose tissue and then can sort of slowly be released, fentanyl has something similar, which, as we'll talk about in just a minute, has actually made buprenorphine initiation a little more tricky. The other thing, just from a clinical standpoint, that's important to note, there's only been one study that I've seen so far, which is referenced here at the bottom, that looked at sort of urine toxicology positivity for fentanyl and norfentanyl. Again, you know, we've probably all seen clinically that we have a patient and they say, no, you know, I haven't used fentanyl in 2 weeks, but we're still seeing a positive norfentanyl result on the UTOX. So this study looked at folks who were actually in a residential treatment facility, and because they were in this highly controlled environment, they continued to do urine toxes while they were there receiving treatment, and looked at how long did it take before their urine tox came back negative. The mean was 13 and a half days in treatment before the urine tox was negative for norfentanyl. And there was one individual, sort of the furthest outlier, who still continued to test positive for norfentanyl for 26 days. So just to give us a sense, right, like this is really sticking around among people who use fentanyl chronically. So what we've seen is that as fentanyl has become more and more available, and as it, for in many places, has become like the main substance, the main opioid that's available, we've seen more people really struggling with buprenorphine initiation. Interestingly, though, it doesn't seem like it's everyone, and we'll talk a little bit more about that. But this is something that I've heard consistently from folks across the country, that yeah, we're seeing more precipitated withdrawal, but it's not consistent. It's not every time, even among people who we know are using fentanyl chronically. Um, at least anecdotally, we're hearing reports of increased tolerance and often need for using higher doses of buprenorphine or methadone for treatment. And of course, high overdose risk with return to use, just again, because of its high potency. So why are people having precipitated withdrawal? You know, and again, I apologize because I know for some of the folks specializing in addiction, this is sort of obvious stuff, but just to make sure for folks who don't practice addiction medicine. So when the opioid receptors in the brain have buprenorphine, or I'm sorry, have a full agonist opioid attached. So this could be anything. This could be oxycodone. This could be heroin, and then you give buprenorphine. So buprenorphine has a really tight binding affinity, so it goes and it binds to those receptors very tightly and it pushes out all of that full opioid agonist. So the opioid receptors go from having sort of the full effect, the full opioid response, and then as the buprenorphine attaches, it brings that receptor activity down, and this causes people to go into opioid withdrawal. And so we've known this for a long time, and we've been able to manage it in the past with when someone, for example, would be using heroin. You know, we were careful. We made sure people were in a little bit of withdrawal before we started the medication. And what we've seen with fentanyl, again, we think because it sticks around so long, is that some people, even after they're, you know, have waited 12 hours, even after we're scoring them on the opioid withdrawal scale as being what we would have previously considered like sufficient withdrawal, we're seeing that they're still having precipitated withdrawal as we administer buprenorphine. So we've seen this sort of outpouring of new approaches. So historically, The traditional dosing, and this is what's in this column right here, was that the general approach was we wait until somebody has sufficient withdrawal, which was typically a COWS score of 8 to 12, or a clinical opioid withdrawal scale score of 8 to 12. And then we would give a first dose of 4 milligrams. We'd wait a couple hours, give a second dose of 4 milligrams. The early days, we only went up to 8 on day one. Increasingly, we were seeing protocols going up to higher doses. And so this was sort of historically the way that we approached pretty much every patient. You know, it was studied in multiple settings, in the emergency department, and definitely in the outpatient setting. And this was the general approach. Now, when we actually were preparing this presentation, I thought this was really interesting. I worked with a few colleagues to present something similar at the Wisconsin Society of Addiction Medicine meeting. One of the things I quickly realized is that we were using these terms like low dose and high dose and microdosing, but actually like no one agreed on what counted as, like, it wasn't that we were disagreeing, it was that there was no standard definition. So I just want to acknowledge I made this table. There, you know, exactly how people refer to this varies a little bit in the literature. So I tried to look at sort of what are the similar factors. So there's this a newer approach called low dose initiation. Sometimes people refer to this as microdosing, where you start at really low doses. So usually 0.5, most of the studies are 0.5 milligrams sublingual for the first dose or even lower. And then you increase up to about 16 milligrams over the course of 3 to 7 days. This, again, was largely created for circumstances, or the idea behind it was that really when we have high concern that someone's going to go into precipitated withdrawal, right? So somebody who comes in and says, nope, I've tried to start buprenorphine and the last 3 times it precipitates withdrawal. And yes, I've been using fentanyl for a long time. So that is one circumstance in which we've seen this really emerge as a promising practice, or a best practice, I would say. The other place we see it being used a lot is in hospital. When somebody's coming in really severe acute pain, they have OUD, they meet criteria to start buprenorphine, but we have concerns about our ability to sort of manage their pain while simultaneously starting bup. So those are sort of the 2 main settings where we've seen this used. It's been primarily studied in inpatient settings, although increasingly there are protocols to be used in outpatient setting, and we'll talk more about that. And then finally, this third approach, which is sort of, it has different names. Again, rapid start, high dose initiation. Sometimes people call it macro dosing. This idea that we're going to give a much higher dose to much more quickly get people to that stable or sort of goal dose of buprenorphine. This, I will say, I have not done. I'm really interested in our discussion whether or not other folks have been using this. Usually the first dose is greater than or equal to 8 milligrams. And the idea here is really that you're getting to your full dose on day one. So the second dose could be anywhere from 8 to 24 with a max of about 32 is what's being recommended right now. The one key thing I want to acknowledge is that, you know, whether you're using traditional dosing or a high dose initiation, those are times when someone has to be in sufficient withdrawal. If they're not in sufficient withdrawal, you will precipitate withdrawal. The one benefit, there are probably multiple potential benefits, but the main one that I would think of with low dose initiation is that you don't have that need for precipitated withdrawal. So with high dose initiation, there's only one published study I could find so far, and I'll review that quickly with everybody, but it was in the emergency department, and the only places I've heard of using high dose initiation are emergency departments, though I will be really curious if anybody's tried this in the outpatient or inpatient setting as well. So just a few slides on sort of these different approaches, and then we're going to jump into cases, and I'll be hoping for some participation. So the first approach, I'm not even going to talk about traditional dosing because I think a lot of folks are already familiar with it. So I'm going to focus on the cross tapering or low dose initiation approach. So in general, when you're using low dose initiation, I think the first thing to remember is that we're trying to really slowly over the course of 3 to 7 days sort of start to just barely nudge out the full opioid agonist. So again, going back to this graphic, you can see here that there's still full agonist opioids in someone's system, and then you're going to give buprenorphine, but just a little bit of buprenorphine. So it's going to start to displace the full agonist, but really slowly. So in the hospital, we'll often talk about like, we're going to give you little baby doses while you're still taking, often it's hydromorphone, but while you're still taking this other opiate, and it's just going to slowly start to build up in your system. So you never have that big jump, right, from the max to like way down in terms of your mu opioid receptor activity, that this is happening really, really slowly over the course of days. Again, in the published literature, this primarily starts at doses of 0.5 milligrams of buprenorphine or less. In hospital settings, there are protocols that use IV and patch. We don't really have those available at University of Wisconsin, but definitely other hospitals are doing that. This is often used for methadone conversion, although sometimes in those cases they're taking much longer than 3 to 7 days. But again, the idea and the concept is the similar. And there is a 3 to 8 day duration, at least in most protocols. So sort of shifting gears and talking about high dose initiation and rapid start. And I know some of the fellows have had questions about like, well, when would we use that? And Rebecca, I see your name on the screen. So I know at one point you were like, well, why don't we think about macrodosing, or like, when would this be applied? And my response at the time was like, I don't know anyone who's done it, and I feel really nervous about it, which was maybe not the best response. But you know, this has really only been studied in emergency department settings where all of the dosing is monitored. And so, you know, it does require that someone is in adequate withdrawal. A lot of these protocols that I'm referencing come out of San Francisco. I just want to acknowledge that San Francisco was late to the game in terms of having a fentanyl really heavily in their supply. So a lot of their materials suggest a COW score of greater than or equal to 8. I feel like in Wisconsin, I would say a COW score of at least 12, just because we know how much more fentanyl there is, and I'm a little bit more cautious about precipitating withdrawal. But the protocol, which I'll show you on the next slide, that they used in this single study that was published by Andrew Herring, was that they were in an emergency department. The person had to have a COWS score of greater than or equal to 8. Then they gave an initial dose of 4 to 8. They reassessed the person within an hour. And then their second dose ranged from 8 to 24 milligrams. So the idea is that they got a max dose of 32 on day 1, but they really sort of optimized that dosing right then and there in the emergency department. There are also separate protocols looking at post-overdose reversal. And again, I haven't seen much in the published literature looking at outcomes, but the recommendations there are that you just need a COW score of greater than 4, and that you can give doses as high as 16 in a single or divided dose pretty much immediately after the overdose, as long as they have some withdrawal symptoms. So this is the study I mentioned from Andrew Herring looking at this high dose initiation. And again, they COW score greater than 8, you give 4 to 8 once they get there, and then you reassess, and you can give up to 32 before they leave the ED. So what did they find? They considered people who were included in this study were people who had gotten more than 12 milligrams during their emergency department stay, greater than or equal to 12 milligrams. So in total, they looked at 366 high dose encounters, and they found that about a third of those individuals, or a third of those encounters, had received greater than or equal to 28 milligrams in the ED, which is pretty I think different than what we would do typically on the inpatient or outpatient setting. You know, often we'll only get up to 12, maybe 16 on day 1. So the fact they were going up to 28 was, I think, important and interesting to think about. Then they looked at 2 main outcomes. So they looked at precipitated withdrawal, and only 5 cases, so a little over 1% of encounters ended up experiencing any precipitated withdrawal. Interestingly, 4 out of the 5 cases of withdrawal happened after someone had only gotten 8 milligrams of bupe. So it's not necessarily that like, oh, if they got 24, or they got 28 or 32, that was what precipitated withdrawal. It seemed like it was, if it was going to happen, it was usually going to happen after that first dose. And then the way that they responded in each case was that they just gave additional buprenorphine, and in each case that treated the precipitated withdrawal. So they just kept going. So even if somebody started having withdrawal, they would just give more, was their response. And for these 5 folks, these 5 individual encounters, it seemed to work. They also looked at adverse events, and they found that about 2 to 6% of people experienced nausea or vomiting, but they found that that was not dose dependent, and there were no cases of respiratory depression or sedation, so no sort of negative side effects as it relates to giving higher doses of buprenorphine. So I am interested in when we get to some of our cases, I would love to hear people's thoughts on like if folks are planning to try this in, you know, in other settings other than the emergency department, because I think, you know, this seems really promising, but unless you're in a highly monitored setting, I still feel a little bit nervous about the dosing. But again, we'll love to hear from others. So this is where I'm going to jump into cases, and I see today, and our fellows will probably recognize some of the cases here because these are all sort of real life patients that we've met, de-identified, of course. So I will get started, and I'm going to ask folks to jump in just a minute with their thoughts. So this first case is an inpatient case. Mr. J is a 32-year-old man who's admitted with a septic joint and severe opioid use disorder. He got 30 milligrams of oxycodone in the ER, and when you go see him, he's experiencing 10 out of 10 pain. He says that his daily, he uses heroin or fentanyl, like whatever he can get daily by injection, and he estimates about 1 to 2 grams a day, and he last used right before he came in. He says that if his pain isn't better managed, he'll have to leave prematurely because he doesn't think that he can handle the pain. And he denies any current withdrawal symptoms, right? Because he used right before he came. And he's used buprenorphine in the past, but never in a formal treatment program. But he has found it helpful when he tries to self-manage his withdrawal symptoms. So you make a diagnosis of opioid use disorder. You talk about treatment options. And he says that he is interested in buprenorphine, but he's really worried about his pain. He doesn't feel like he's concerned that he's not going to have adequate pain management if we start him on buprenorphine right now. So we then talk to the ortho team, and they say that they anticipate he'll be in the hospital for at least 14 days for administration of IV antibiotics. And so I'm curious, I'd like to hear from attendees, what would people do in this case? Like, what are your thoughts? Do you have other questions?
This is Laurel. I guess my first question is, what is he willing to do at this time?
Yeah, that's a great question, Laurel. Because I think sometimes we talk to people, right, and they're so nervous about any number of things, and appropriately so. So understanding what they're open to trying. Anybody else?
This is Kelly. In asking him what he's interested in too, I think sharing education about the options regarding how to start buprenorphine, because a lot of people have had an experience either prescribed or otherwise with a more traditional approach, and perhaps are fearful of the pain they'd go into, the withdrawal they'd go into, precipitated withdrawal if they had that in the past. And I don't think everybody is a bit familiar with low dose initiation. So I found that to be a good conversation starter.
Yeah, thank you.
See family medicine at Access Community Health Centers. It sounds like for pain control, sounds like this is a scenario where we could use BID dosing of buprenorphine to better cover pain. Would you agree?
Yeah, and we're going to talk about frequency of dosing. Thank you so much for bringing that up. Absolutely. So I'm going to go ahead and move on, but because we have more cases, and so I will continue to invite people to jump in. So thank you guys for those of you who did. So I will just say, when I'm in the inpatient setting, I'm always in meeting a patient for the first time that has opioid use disorder that's open to the concept of starting buprenorphine. I'm always thinking about three things. I'm thinking about how much pain are they in? What is their current level of withdrawal? And how long are they here? Because once we have that information, we can then make a plan. To Laurel's point, like you'll see, I made this table, and like there's a bunch of so there are often multiple options even within those three things. But if I'm meeting somebody who's leaving tomorrow versus meeting somebody who's going to be here for 2 weeks, I might think about my approach a little bit differently. And so I think, you know, this sort of framework has really been helpful for me. So for this particular individual, right, he's in high pain. He's in no withdrawal because he used right before he came. And we're anticipating that his length of stay is going to be long. So I think in those cases, you know, we are already anticipating he may end up needing some full opioid agonist. And we're not in a huge rush. We have 2 weeks, right? We have time to be able to help him initiate and get to a more stable dose of buprenorphine. And we know from the literature that if we are not really proactive in addressing his pain, the chance that he actually makes it those 2 weeks is relatively low, or the chance that he ends up feeling the need to like use in his room, which we know also happens a lot. So we really want to be able to treat his pain very proactively. We want to be able to start him on buprenorphine, and in this case, we have time. So in a case like this, I would usually offer low dose initiation as sort of first line. It can also be reasonable if somebody's just like, no, not today, right? Like, if what are you willing to do? And they're like, I'll talk to you about this, but not today, not until my pain's better. Like, I can't even think about it right now. Can also be reasonable to wait a couple of days and come back. And that's something that we do pretty frequently, especially when somebody's there with a prolonged course of antibiotics that we know they're going to need. So in this case, we did just what was described. We talked to him about treatment options. He really just felt like low dose initiation was a good option for him. He was really, I think reassured by the idea that like, hey, we're going to keep giving you hydromorphone. Like that's not going away. And we're actually going to recommend that the dose goes up quite a bit because your pain isn't well controlled right now. We know you're going to be here for a while. We'll have plenty of time to get your bupe up. And he wasn't currently in any withdrawal, right? So we didn't want to be more sort of aggressive, if you will, with the higher buprenorphine dose because that would have likely precipitated withdrawal. So this is a protocol we've been using for a while. We adapted it from a group in Vancouver. The original study, they started at 0.5 milligram of buprenorphine on day 1. And University of Wisconsin, interestingly, will allow us, pharmacy will allow the nurses to cut the films in half, the 2 milligram films in half, but they're not allowed to cut it into fourths. And so 1 milligram is the lowest we can give, but I will just say a lot of other institutions start at even lower doses. The first couple times I did this, I was a little bit nervous. Like, oh, I even talked to Dr. Nolan, who was the PI on the Vancouver study. And I was like, have you ever done a milligram? And she was like, no. And I was like, do you think it'll be okay? She's like, I think so, but let me know how it goes. Luckily, it's been fine, and we haven't had anyone precipitate withdrawal with just a milligram. But the idea is that, again, you start low, you slowly increase the dose over the course. In this protocol, it's about 7 days. And at least in those first 6 days, 5 or 6 days, you're still giving full opioid agonist. And so all of their analgesic needs should be met by that full opioid agonist as you're sort of slowly increasing the buprenorphine dose. Then when we get to about day 6, when they are finally at 12 milligrams of buprenorphine, this is when we start thinking about, okay, can we start reducing the hydromorphone dose? And I will say we generally prefer hydromorphone to oxycodone or other pain meds because it has a higher binding affinity. And so in conjunction with buprenorphine, it tends to work a little bit better. And then on day 7, again, a lot of this depends on kind of if their pain is much better controlled, and let's say they're infectious, whatever reason they're there for is improving. A lot of times at that point, you can actually pull the hydromorphone off pretty rapidly. If they're still sort of undergoing treatment and having a lot of pain, it kind of becomes this balancing act between how high up do you go on the bupe and when do you start to taper off the hydromorphone. But I think, our approach generally on these first 5 days or so is really consistent. And then once you get to about day 6, it depends a little bit on the patient's level of pain. So this is literally what I put in the chart. And it's, really guidance for the team. I think other things that we're always thinking about, we want to make sure that we're maximizing all non-opioid pain meds. So scheduled acetaminophen, scheduled NSAIDs, gabapentin when appropriate, recommending that APS get involved if the patient is open to trying ketamine, in particular if their pain is really poorly controlled. And again, we're really trying to dose opioids based on the patient's pain, and that we're, a lot of times primary teams understandably get really nervous because the MME looks so high. And so just really giving a lot of education and support and reassurance that like, hey, their opioid tolerance is already really high. If their base is here, if they're in withdrawal, if they're having withdrawal symptoms on what we're giving them, like we're not even meeting their baseline, let alone touching their pain. And so just giving some reassurance and saying like, hey, we'll hold it if they're overly sedated, if they're not waking to voice, if their respiratory rate is reduced, but otherwise we need to really base it on their reported pain. And then finally, really until we hit about 12 milligrams of buprenorphine, we shouldn't expect that they're getting a lot of analgesic benefit at those low doses. So, really, again, use the full agonist. And then once we get to 12, we really want to try to use split dosing, which was brought up. Usually in the hospital, at least, we'll try to do 3 to 4 times a day dosing. to maximize the analgesic property, which is always a little confusing to me because it has such a long half-life, but the analgesic properties only last about 4 to 6 hours. So we really want to try to optimize how often they're getting the buprenorphine. So I will just say we've used that protocol quite a bit, and I think we've seen really generally good success when the patient is like sort of bought into the concept. I think it's sometimes a little scary for people who have experienced precipitated withdrawal, but I think we've seen it used with a lot of success. I wanted to pause here and just see if anybody had any questions or comments on this case, or if you've seen things done differently in other institutions. Okay, hearing silence, I will go on to the next case. So the second case is a woman who's 25 years old. She comes in with a history of opioid and methamphetamine use. She was admitted after a motor vehicle collision. She had splenic injury and pulmonary contusion, and our team was consulted on day 2. So when we looked at her chart, we saw she got oxycodone 15, fentanyl 150 micrograms, and hydromorphone 0.8. We were going to see her, and Laurel, you might remember you saw this patient. We were going to see her sort of like late morning, and so far that day she had gotten oxycodone 30 milligrams. So that the diagnoses that our team made were severe opioid use disorder and severe methamphetamine use disorder. And in conversation, she said she was open to the idea of starting buprenorphine later, but she was really concerned about precipitated withdrawal and really concerned about uncontrolled pain. She really wanted to continue on full agonist opioids for now. And so with that little bit of information, what questions would you guys have?
I would be curious about what her definition of later is. Like, is she talking later in the hospital stay, once she's discharged?
Yeah, thank you. That's a great question.
This is Laurel. I guess just always unpacking what patients' previous experience with precipitated withdrawal looked like, and as an entry point to provide some information.
Yeah, thank you. And I think similar to the question that was raised first, you know, one of my questions here when this case was not as clear as far as like when she was actually likely to be discharged. So I think one of the key things on my mind is like, how long is she here? Like I don't still know that much about like what's a typical course for splenic injury and pulmonary contusion, or like what was the severity of those injuries and how long will she be here? And so I was curious about like, how long are you going to be here? What does her anticipated recovery look like from these injuries? And what is the follow-up care plan? So that was where we started. And when we talked to the team, so they consulted us that morning, and then we saw her, and then like we're trying to plan this longish term plan, and we talked to them like, oh no, she should be ready to go in a few hours. And we were like, what? What do you mean in a few hours? And then I said, okay, well, what's your outpatient treatment plan, right? Like she's been getting oxycodone since she's been here. Like, what are you going to give her? And they said, oh, we're not planning to give her anything. We don't usually give people with these injuries anything. And at that point, I was a little bit nervous, like, oh man, like, so they're going to send her out with no opioids. So then I think, okay, well, does she have a primary care provider? And maybe she'll be able to follow up with that person. She had Badger Care, but had never met that person. So then we were kind of in an awkward position. We went back in and presented her with this information of like, hey, so you might actually be ready to go soon. It doesn't sound like, you know, and actually I think we may have had the team go in and say like, you're going to be ready to go pretty soon, and we don't think you're going to need any opioids at home. Like that was not their standard of care. So then we were able to go back in and say, okay, so let's think more critically about this buprenorphine issue. Like, do you want to start this now? What are the options? So that was what we did. We had already assessed her COW score, and it was still low. It was a 5 when we first saw her. By the time we did all of those other conversations, I think it was a little bit up, like a 6 or a 7, but still not very high. And so at this point, we know that she's going to leave relatively soon. They're not discharging her with any opioids. She doesn't have a primary care provider that she knows. And when we talked to her, she was open to starting buprenorphine, but continued to be really terrified, just like, there's no way that I can handle going through withdrawal. I'm not going to tolerate it. It's not going to go well for me. She had a lot of sort of ideas about how this would go, and just that she had been under so much stress, someone who had been in the in BC with her had actually died. So there was like a lot of new trauma. She was like, I just can't tolerate any withdrawal. I know that. So we were like, okay, so now what would you do with this new information that she's leaving soon? She doesn't have a PCP. She's not going to go home with opioids. What would your thoughts be?
This is Rebecca. I'm curious if it came, or one of the fellows, I'm curious if it came up as a possibility for her to be able to stay around long enough to consider to have a cause where she could be considered for this high dose induction of the buprenorphine, since it sounds like she might be too nervous to really work through a low dose, more extended induction after she leaves.
Yeah, great question.
This is Kelly. It sounds kind of like a case I got called about yesterday. Oh, and I have an assistant, a 3-year-old assistant in the background, if you can hear her, sorry. So I mean, I think sometimes this is our opportunity. Henry, can you be quiet for a minute? Sometimes this is our opportunity as consultants or specialists to educate the primary service too about the risks of discharging her fairly rapidly, receiving full opioid agonists with nothing, and risk for returning. And sometimes you can do a low dose initiation to avoid her fear of withdrawal, but do it more rapidly than some of the published protocols or case studies do it. So there's like a middle ground in trying to do it over the course of maybe 2 to 3 days. It's kind of a in between the traditional and the macro dosing or whatever. So I don't know, like reach out to the primary service, help them think through what they think is their plan, and consistently try to educate the patient to get her on board to maybe start. It's a hard one.
Yeah, and I think, other contextual factors in this case were that she had re-engaged with her mom just after this accident, and her mom was going to take her home, but both the patient and the mom were like, oh, she's not, like, they were both like, she's not going to tolerate. And so it was this really kind of, like, they were very clearly telling me that they didn't feel safe with her going home without anything in place. And so I did exactly what was sort of being asked about, which was, we called the primary team and we're like, look, like this isn't like, we need a little bit of time. Like I need a day, like we need a better plan for her, especially there hadn't been any outpatient primary care follow-up organized. So we're just all these layers of challenges. And we knew that when she left, she was going to be in withdrawal if she wasn't leaving with opioids. So I had never seen anything in the published literature, but I just thought philosophically it makes sense, right? Like scientifically it makes sense that we can just sort of expedite how quickly we go up on the bupe. She wasn't getting that many opioids, right? It's like she'd only gotten 30 mgs of oxycodone that day. The day before, I don't remember exactly what her MME was, but it wasn't so high. And she was in a controlled setting. And so what I worked out with the patient, and she, Rebecca, to your point, she was very clear. She was not going to do a traditional or even a high dose with like withdrawal. She was not going to tolerate withdrawal. She was very clear. She did not want to be in withdrawal. So again, she had just had this new trauma. She was under a ton of stress. So this is what we came up with. So I said, well, let's try giving you these baby doses, 1 milligrams every 2 hours. And this was at this point like 4 p.m. because it took a lot of time coordinating all the other pieces with the team to get them to like sort of agree like, yeah, she can stay. And I said, let's just try it. You get a milligram every 2 hours, you'll be up for another milligram. If you're feeling fine and you don't want it, you don't have to take it. But otherwise, every 2 hours, the nurse is going to come in and offer you, another milligram of bupe. We'll do this overnight. So over the course of 16 hours, so that by the time I see you in the morning, you will have had up to 8 milligrams and we'll see how you're doing. We ordered other supportive meds. So clonidine was there, ondansetron. And then I promised her I'd come in and see her first thing in the morning. So I went in the next morning. She had gotten all 8 milligrams. She did say like, well, I had some mild sweats. I had some mild chills overnight, but she felt really overall pretty comfortable and it was very manageable. So at that point, she'd had 8 milligrams. Of course, because of bed capacity issues, there was some pressure to sort of help her leave relatively soon. So what we decided at that point was that I would send her out with 4 milligrams. She could take it either 3 or 4 times a day, depending on whatever she needed. I gave her enough meds to get to 6 days out. Thank goodness for Mary Vasquez at Access, who helped me to have this patient reassigned to Alyssa Brolman, who's I believe is on this call. And then Alyssa became her PCP and Alyssa saw her 6 days later. I will say, I was super happy because the patient made it for follow-up, and my understanding from our team is that she's actually doing really pretty well right now, and has continued to remain engaged in care. And I included this case because I think it sort of highlights, I don't really think, I think this idea historically that we have like this traditional approach that we're going to use the same buprenorphine initiation every time. I think with where we are right now, like that's kind of out the window. I think the idea is that we're always working against all of these other sort of psychosocial factors like disposition planning, patient's level of pain, level of tolerance to withdrawal, concern for precipitated, like all of these factors, and that increasingly there are just a bunch of different ways to do it, which I know is a little bit overwhelming for folks newer to the field, but I also think it can be a little bit liberating that like there's no one right way. And the reality is, and the next case is an outpatient case, the reality is that when our patients do this on their own outside, they're doing all kinds of stuff with it anyway. So to the point that Laurel brought up earlier, a lot of times it's like, how do you want to do this, right? Like you've probably tried this medicine before, like what's worked for you and what makes sense for you. We can give you some options, but we want to hear from you. And if it's not going well, especially inpatient, right? Like, so the nurse had my cell phone number that night. Like if things go sideways at midnight, like just call me and we'll figure out a new plan. But like, let's just try it because it feels a lot safer than the alternative.
Can I say one thing? This is Kelly. Alyssa and I are caring for this patient, and she's done tremendously well. But one thing that she has repeatedly reflected it on is how supported she felt in the hospital when she was scared to do this. And so I think it's a testament to the fact that like whatever you're going to do, to be really, I like to describe our role as cheerleaders for these patients, because they're often nobody else is cheering for them or, voicing, that they have faith in them. And so she just really felt empowered to do something she was scared of by having a lot of support and education from the team. Again, sorry for the background noise, but I think if you can be confident for the patient, it goes really far in these cases.
Yeah, thanks, Kelly. And this one was really hard because she was trying to get me to promise it was going to go well. And in my head, I was like, oh God, I've never even seen this in the literature. Like, I am totally making it up. And I was like, I can promise you that if it doesn't go well, your nurse can call me. Like, that was like, I wasn't going to lie. But yeah. And I mean, I think the reality, I spent hours that afternoon, like between getting stuff set up at Access and in the room with the mom and calling the team and back talking to the nurse and back talking to the mom and the patient. And I mean, it took a lot, but it was also one of those times when luckily it was not a super busy afternoon and I was able to swing it. And also it was one of those cases where you could like almost envision, like the patient and her mom were telling me like, oh no, if you send us home with this current plan, she's gonna use. Like there's no, like there was no ifs, ands, or buts about it. And so it was just like, okay, well then let's just try it, right? And I can't promise you that it's gonna be perfect, but I can promise you if it's not going well that I will talk to you. I will call you, I'll be on the phone, we'll make a new plan, we'll figure it out. And I think sometimes that's like the best that we can do. And luckily, in the end, she was agreeable, and it thankfully went really well. And she's had great follow-up care with Kelly and Alyssa.
That's a really great example. One question I have is, even though it sounds like they probably wouldn't have called you in the middle of the night saying that she had worsened withdrawal, if they did, what would have been your approach at that point?
Yeah, so I think it would have been dependent on like how much has she gotten, right? How much buprenorphine has she gotten? What are her symptoms? A lot of times, as we all know, when people say they're experiencing withdrawal, it could be from something else entirely. So it could be that they're just really anxious and they're experiencing that as withdrawal. And so sometimes it's just talking through with people. If it's symptom management, right? So like the number of times we have these like PRNs ordered that just aren't offered. So if it was nausea, making sure she's getting on Dancitron. If it's anxiety, making sure that she already got clonidine, or maybe even considering something else like hydroxy, like any number of things that we could sort of give in the moment to reassure people like, hey, we're working on it. If it was precipitating withdrawal, I mean, the other option is just to kind of blow through and give more bupe, like similar, akin to what they do in the emergency department. And that would have been my back pocket plan. But this note was also quite long, and I talked to the nurse like ad nauseum about like, here are all the things to do. Like check the cows when you go in, make sure you're offering all the PRNs, make sure that you're getting in there every 2 hours. Don't wait for her to call you, like kind of trying to stay ahead of it. And I think that helped a lot. And it also, to Kelly's point, I think the patient felt more assured that the nurse was going to be on top of it, because I think a lot of times our patients feel like, I don't want to ask for it because they think, in quotations, like I'm a junkie, or they, treat me badly because I'm asking for the meds that I really need. And so we were just all on the same page, and it took a ton of time coordinating. So I don't want to say like that it's always easy, because it's a lot of coordination, but luckily we had a really good outcome for this case. I do want to get to this outpatient case quickly. So I am going to go ahead and move forward if nobody has any objections. And I think we have a few other outpatient providers here. So I'm interested in what other folks are doing. So this is a case of Mr. M. He's 51 years old. He comes into clinic asking to start buprenorphine for the treatment of opioid use disorder. He has a 30-year history of heroin use. He used to inject, and now he only uses via insufflation. His only prolonged periods of abstinence really in the last 30 years are times when he's been incarcerated. So if he's not been incarcerated, he's pretty much been actively using. He has a remote history of methadone treatment. He did get up to a max dose of 90 milligrams, but it's really clear he's not interested in methadone at this time. He has gotten buprenorphine a few times in the past when he was in withdrawal, and he was really concerned because buprenorphine had made his symptoms worse. That said, he really didn't like the confines of methadone treatment. He wasn't interested in extended release naltrexone, and he did want to stop using. So he comes in today wanting to start bupe, but really also very worried about experiencing withdrawal. We did discuss all 3 forms of medication and make a diagnosis of OUD. But, sorry, my slides are like glitchy here. But sort of where he landed is that he was really still interested in buprenorphine. He tells us that he works most days of the week. He has a job where he kind of shows up, and if they have work, he gets assigned and he gets paid under the table. This also means he doesn't have any like benefits. He doesn't get sick time, right? If he's not working, he's not making money. He's experiencing homelessness and he sleeps in his car, which also means, right, he doesn't have easy access to a bathroom. So when we think about withdrawal and where someone would be experiencing that, that's a really tough situation. So we talk about options, and we offer the option of low dose initiation, which he ends up wanting to do because, again, his primary thing is like, I don't want to go through any withdrawal. I can't tolerate it. I'm not going to tolerate it. I have to be able to go to work, and I don't have easy access to a bathroom. And he had this past experience of precipitated withdrawal. So I think that's it. Just for the sake of time, I'm going to move forward. And so I already gave up a little bit that we ended up doing low dose initiation. And I really want to get to the discussion here and kind of explain what we've seen happen a lot. So I had created this handout for patients because we see a lot of folks at Wingrove with low health literacy. And I tried to make it as simple as possible. It's a very similar protocol to what we use in the hospital, but it's just morning and evening, as opposed to like multiple times a day dosing. I put visuals so that even if you don't know how to read, you could, hopefully still follow this relatively easily. So like morning has the sun and evening has the moon, and we only give 2 milligram films because, the idea was that it should theoretically be easier than if you get 2s, 4s, 8s, etc. Jumping ahead for the sake of time, I mean, I think what we've seen the few times we've tried to use this low dose initiation protocol in the outpatient setting is that it's just really hard for people to follow. And this gentleman in particular, because he kept trying, but he, we gave him this, and basically for months and months, he would kind of come back, have taken a couple doses, but like really unclear, like when he took them or how he took them. We would try calling him in between. We often couldn't reach him. His toxicology reports, although he would repeatedly say like, yes, I've been taking some, were intermittently positive for bupe. So like didn't have consistent sort of toxicology evidence, for lack of a better word, that he was consistently taking it. He was consistently still using fentanyl and other opioids. And just at the end of the day, like just stuff didn't align. And he eventually was lost to care. So this was not a good outcome. And I think one of the things that I've really struggled with, and I was really interested to hear from others today who work in other outpatient settings, is sort of if you are using low dose initiation in the outpatient world, like have you had it go well, and what does that look like for you, and like what protocol are you using? And I think for this gentleman in particular, he had a lot of cognitive deficits. And I just think it was too complicated in a lot of ways, and probably too complicated for just sort of his life and where he was. So I wanted to open up the floor and ask if others have had good experiences with low dose initiation in the outpatient setting. Any thoughts on this?
I have a little bit of a different situation. It's not really low dose initiation, but it is a veteran that I've been caring for in Suboxone Clinic who really had trouble getting back on it after a relapse because he continued to have precipitated withdrawal. And our Suboxone Clinic is just once weekly. And he kept having precipitated withdrawal and was not showing up for our clinic. And he took himself to an OTP where he had to come daily. And for some reason that worked for him. That daily contact where someone administered his dose on a daily basis seemed to get him through the hump. So for whatever that's worth.
Yeah, thanks, Laurel. You know, I just finished reviewing abstracts for ASAM, and there was a abstract submitted from, I guess maybe I shouldn't say since it hasn't been formally approved yet, but where they give this case of someone who came back to their emergency department 5 times, and they kept trying to initiate, and a couple of times he got admitted, and he would leave prematurely every time, like leave before he had been fully initiated. But I agree. I think, you know, in talking to folks in other spaces, I think the idea of like observed sort of dosing with a lot of other medical monitoring and, you know, very sort of directive assistance around, okay, these are your symptoms, we'll give you these supportive meds, et cetera, is an approach I've heard a lot of folks taking. I'm realizing I'm way over on time. So I will just say I made this lessons learned slide for outpatient. And I think, you know, I am kind of at the point, we've tried it enough now where I feel like I'm really reserving this for special circumstances. Like I'm not recommending this as first line. I think, you know, if somebody has a history of precipitated withdrawal, if they are telling me like, look, I'm not going to tolerate any withdrawal, like that, like waiting game, like I can't do that. I've tried before, I can't do it. And when they have a lot of confidence in their ability to maintain meds, I think those are sort of the right mix of circumstances. Not that I would withhold it from anyone, but I just think we haven't seen a lot of people be able to really follow it, at least with the structure we have in our clinic. There are multiple times when I think I'd avoid it. So definitely if somebody prefers a rapid start, if they're like, no, I don't want to spend the first week continuing to use, like my goal is to stop right now, I think those are times when I wouldn't use it. And I did just also want to acknowledge that the California Bridge materials do have this 3-day sublingual cross taper. So I think if I was going to do it again, I would probably try using this, which is where you just use 0.5 milligram every 3 hours. So again, somebody has to be willing, right, to every 3 hours during the day. To redose, but you get up to a total of 4 on the first day, a total of 8 on the second day, and a total of 16 on the third day. So I think this could be another good option. And then they also have this rapid self-start where you start with an 8 milligram dose, which again, like gives me palpitations a little bit, but it is, you know, and really in that circumstance, they recommend that people wait as long as they can, and then you give these supportive meds. So I actually had a few more slides. I'm really sorry. I did not mean to go this far over, but I really appreciate everybody jumping in and having some conversation. And I want to thank everybody for being here. I'll stay on for just a couple minutes in case there's any general Q&A, but out of respect for everybody's time, otherwise I will let you all go. Thanks for being here.
Thank you.
So if anybody has any questions, again, I'm sorry I didn't get through these last couple things. I'm happy to answer them.
Elizabeth, it's Alyssa. I have like minimal to no voice, but I did put like a question in the chat.
Yeah. Yeah, maybe I can
access.
see it. Yeah, it's this weird view. I'm so sorry that
I think I have enough. Anyway, I'm just gonna say it. So I enjoyed kind of hearing, just remembering that this could be a patient-centered discussion about the 3 approaches. And just wondering if like, have you seen, I know the California Bridge has a lot of nice handouts, but have you seen any like handout that kind of summarizes these three approaches so that patients can kind of process it from a decision-making standpoint?
I have not. And Alyssa, I think this, like, different patients are obviously very different. I think I have found, at least in the hospital side, in outpatient, like sometimes it's so much information, right? Like it's even a lot of information for clinicians to really kind of sift through. So I have found that, I've kind of am trying to like internally process all of this information about like what are your social circumstances and what is your tolerance for withdrawal, and have you used bupe in the past? And like in outpatient, like we just had a new patient this last week, and I was just like, how do you want to do this? Like she's been like she's been in treatment so many times. She's been on bupe for extended periods. She's been on and off fentanyl. She just left incarceration fairly recently. And I was just like, how, like, there are all these ways we can do this. Like, and I don't go into details, but I'm just like, what do you want to do? And she's like, oh, I don't even want to mess with any of that. Like, I'm just going to do it the normal way. Like, I know how to do it. I do 4 milligrams. And I was like, okay, great. Go home and do that. And if it doesn't work, then call us tomorrow and I'll call you back. Like, and I think, a lot of our patients, not always, but a lot of our patients like are already using bupe intermittently on the street or like from whatever means they access it. So short answer is no. Even if it was available, it gets pretty complicated. And I think for some people that may just end up being a lot more information. And so I think a lot of times, like I'm kind of like, what have you tried? What works? What are you willing to try? Kind of what are you worried about? And can you tolerate any withdrawal? And based on that, then I might make a recommendation. And if they feel nervous, then give a backup option. But I think like to get into all the nuance of it really overwhelms people, has been my experience. I'm curious if others have different thoughts on that.
That's helpful. I mean, I think that even kind of the discussion about like all the three options for MOUD, that can be overwhelming for patients, and then kind of taking that next step if they've chosen bupe. Anyway, it's just helpful to think about, and I think often trusting what the patient has had experience with and knowledge from as a good starting point for jumping off. So thanks.
Yeah, and I think too, just saying like, what do you know about this? So like sometimes I'll just start like, what, like, do you know about methadone? What do you know about methadone? Do you know about, like, what do you know about it? Because sometimes it's like, sometimes there's misunderstanding, and then you can sort of correct that or ask permission. Can I share some information? But then I think with this, like, have you tried it and what happened, right? And if they're like, oh yeah, I took it last week, like, and now I just want a prescription, then I'm like, great, like, tell me what you did. And I think remembering, like, I often, especially when I was newer to this work, had to remind myself like people are dosing their drugs like every day. Like to pretend like I know what they like how they should dose. Like they are doing this every day. They are making these decisions. They are and so just to kind of respect that. Now occasionally you run into someone who's just hasn't had a lot of exposure or experience with buprenorphine, or maybe they've not tried it, or the one time they tried it, they had a really negative experience. Then there may need to be a lot more coaching. But a lot of times people are just like, oh yeah, like I know, like, okay, tell me what you want to tell me, but I'm still going to do what I'm going to do. So I don't even try to like, I'm not the expert in the room. Like, tell me what you know, tell me what you've done. How do you want to try this? Is it okay if I give you some other ways? If it went bad the first time, can I give you some other options that work really well for some people? What do you think about that? Is kind of how I frame it. Instead of like, there are these 50 ways. Because that sometimes people are just like, oh my God, what is she talking about?